hereditary spherocytosis, which is the common type of hereditary hemolytic anemia, and it is a autosomal dominant inheritance. In these, the red cell membrane is abnormal. Coming to the pathogenesis of hereditary spherocytosis, actually there are membrane cytoskeleton proteins, or skeleton is made up of some proteins which will lie closely opposite to the internal surface of the plasma membrane, and they are responsible for the elasticity and maintenance of the RBC shape. These membrane skeleton are made up of spectrins, ankyrins, bandform 3, bandform 4.1, and bandform 4.2. Coming to spectrin, it is the chief protein component responsible for the biconcave shape, and it has two subunits, alpha unit and beta unit. Ankyrin and bandform 4.2 will bind to spectrin to band 3, and the band 3, which is a transmembrane ion transport protein. Band 4.1 will bind spectrin to glycophorin A, which is a transmembrane protein. So, pathogenesis. The mutation most commonly involve the gene coding for ankyrin will be more than band 3, then spectrin, then band 4.2. Band 4.2 is also called as paladin. Most common defect in hereditary spherocytosis is ankyrin, and most common defect in hereditary elliptocytosis is spectrin. So this can be asked for a MCQ or in a NEET exam, or in the Viva they may ask you the most common defect in hereditary spherocytosis is, the answer is ankyrin, and the most common defect in hereditary elliptocytosis is spectrin. So pathogenesis. Mutation will lead to loss of membrane cytoskeleton proteins, ankyrin or spectrin or band 3 and 4.2, thereby causing the reduced membrane stability, which results in spontaneous loss of membrane fragments during exposure to the shear stress, thereby loss of membrane relative to cytoplasm, and ends up in which will forces the cell to assume smallest possible diameter for a given volume. As a result of this, the cells become more and more spherical, or cells become microspherocytes. RBCs become less deformable. So it is unable to pass through the membrane. So gets trapped in the spleen as they are unable to pass through the interendothelial fenestrations of the venous sinusoids. And these RBCs are phagocytized by the reticuloendothelial system, which will result in extravascular hemolysis because the hemolysis is happening outside the blood vessel. So this is a picture showing the pathogenesis. Primary membrane skeletal defect resulting in decreased membrane stability, thereby membrane loss, and decreased surface to volume ratio resulting in spherocytosis, and there is decreased deformability. As a result, there will be splenic trapping, and there will be erythrostasis resulting in decreased glucose and decreased pH, which will end up in phagocytosis, thereby causing extravascular hemolysis. Laboratory findings. Extravascular hemolysis is seen. So there will be mild to moderate chronic anemia. There will be increased reticulocyte count because of the bone marrow response. There will be unconjugated or indirect hyperbilirubinemia. Splenomegaly will be there. And the characteristic feature of hereditary spherocytosis is the mean corpuscular hemoglobin concentration will be increased due to dehydration caused by the loss of potassium and water. And there will be spherocytes. Peripheral smear shows microspherocytes, which are small RBCs without central pallor. Actually, we know that Normally, there will be central one-third pallor present in a red blood cell. Here, there will be no central pallor. As a result, MCHC is increased. You can appreciate that in the picture shown. Coming to the osmotic fragility test or pink test. It is helpful in testing the spheroidal nature of red cells, which will lies more readily in solution of low salt concentration. That is, osmotic fragility will be increased. We have to take 12 test tubes with different concentrations of sodium chloride, and the blood drop is added to each sample, and you have to note down the hemolysis starting point, and thereby you can note the osmotic fragility. Autohemolysis test. It is similar to the osmotic fragility test, and it is done after incubation, and it shows increased spontaneous autohemolysis, that is 10 to 15% of the red cells as compared to normal red cells less than 4%. Direct Coombs test or antiglobulin test is negative. So it is useful to distinguish the conditions of other spherocytosis, that is acquired spherocytosis, which is seen in autoimmune hemolytic anemias. So spherocytes are seen in hereditary spherocytosis and autoimmune hemolytic anemia. By doing a direct Coombs test, you can differentiate a hereditary spherocytosis and autoimmune hemolytic anemia. Direct Coombs test or antiglobulin test is positive in autoimmune hemolytic anemia. Autoimmune hemolytic anemia is the most commonest cause of spherocytosis. For hereditary spherocytosis is splenectomy. Splenectomy is almost always beneficial in hereditary spherocytosis. After the splenectomy, anemia will be corrected, but still the spherocytes will remain in the blood. You have to vaccinate against the encapsulated organisms like pneumococcus and Haemophilus influenza.